sound good when you introduce me, so I might take you around with me a lot, if you don't mind. So I'm really excited to be here today and to be asked to come talk about some of the work that I've been doing. And it's a collaboration, actually, a lot of it with folks at Duke. So I'm really excited to share that with you as well. My work has really, as Dr. Bartlett said, focused on HIV and addressing prevention and care for youth along the care continuum. Why do youth matter? Why do we care about youth and HIV to begin with? It's really critical because 1 in 4 new infections are occurring in youth, particularly youth who are young men who have sex with men, and men who have sex with men of color, so African American, Latino men. The problem is that many of these youth don't know that they're HIV infected. And so we need to address how to get them into care, get them tested, so that they can reap all of the benefits that we know are effective for those that are HIV infected, as well as the things that we know now can prevent HIV acquisition at those at risk. This is a graph adapted from the CDC, and it really kind of shows pretty evidently and strikingly who's at risk for HIV infection and who continues to be up to the latest year, 2013, where we have data. And the red line looks at Black African American men 13 to 24, who really bear a disproportionate burden of HIV. And this really is seen where we live in the South, where the epidemic is truly kind of at its, at its most active in a lot of different ways. When we talk about HIV, we talk about the care continuum. And it's really just a way for us to understand where people are in terms of their diagnosis and their engagement in care. Because for what we want is we want everyone with HIV to be virally suppressed. That's sort of the end game. That means that they're in care, on meds, and their virus is undetectable. It's important because it prevents transmission to others, and it's also important for their own health. The problem is we're not getting all of those in care suppressed. The purple that's up now is looking for all people with HIV. And you can see that we're still missing people who are diagnosed. Only 86% know they're infected. There's a drop-off between those that are infected and when they engage in care. And there's a lot of different reasons for this. Huge issues with stigma, but also with structural issues such as transportation, access to care. But not everyone who knows they're infected gets into care and stays in care. Less get prescribed antiretroviral therapy, and then less take that therapy every day. So this is the continuum for all people. When you look at those for 18 to 24, and that's currently the youngest age that we have data on, when you even go even younger, the data looks worse. But you can see we're not doing as well. So now we're down to only 13% of those 18 to 24 virally suppressed. Again, this is from nationwide estimates. If you look at different places and different clinics, different localities, they may be doing better or worse. But globally, what we know, nationwide, we have a lot of work to do, particularly among youth. So how does technology fit into this care continuum? How can we use technology to address some of these deficiencies all along the continuum? Well, we know that mobile phones have a large reach. My guess is that most of you have your phone with you. You're probably either looking at it or really want to look at it right now. If it's beeping, Sarah has mine, so if she starts looking at mine, I'll know she's not paying attention. It's appealing. They're fun, right? Everyone has apps. I'm just going to assume everyone has apps. See, Dr. Bartlett has his phone in his lap. He's ready. But we all have apps. They're appealing. They're fun. New things come out. They're low cost. Interventions technology, once developed, they're low cost to disseminate and replicate. Your accessibility in time and space. Again, in-person interventions, you have to show up, you have to get there, you have to be one-on-one with someone. You may not have that ability, but you always or almost always have accessibility to the internet or your phone. Obviously, that has some caveats, but for the most part, saturation is pretty much almost at 100%. Privacy, again, no one necessarily needs to see what's on your phone. You can have multiple different passwords. You can use your thumbprint, and you can turn it off if somebody walks into the room and you don't want them to see that you're looking at something related to HIV. We can develop tailored messages, tailored text messages, tailored algorithms. Interactive, they're fun. Not that interacting in person isn't fun, but it can be fun to do things online and do new things. And fidelity, so the ability to deliver the same intervention to people regardless of the counselor delivering it is another advantage. So it can be, in some cases, easier to evaluate. So we published a review last year, Kate Messig and some others on my team, where we looked at eHealth interventions available across the continuum. And these are published studies. And again, it seems like there's actually a lot of published studies, but when you look across the entire continuum, most have actually dealt with just sort of web-based interventions. So kind of what we sort of used before mHealth, before mobile phones became really kind of the be-all, end-all. And a lot really just address one stage of the cascade. This is things that are in development. Again, you see more. These were our two projects that are led by members of our research team that are in development that I'll talk about today that address different stages of the continuum. So I thought, given this, I would frame this talk to sort of showcase the work that we're doing, again, collaboratively at UNC and with Duke and other collaborators in small businesses to address the continuum of care for youth. So we'll kind of walk through and we'll talk a little bit about our interventions at each stage. So in terms of testing and linkage to care, kind of our newest intervention is addressing this. And the reason is, as I showed you before, is that a lot of young people aren't testing. However, a lot of young people are having sex. And I won't make everyone raise their hands out who's having sex in the audience, because that can get awkward. But a lot of young people are having sex, are having more than one partner, are not using condoms, and are at risk for HIV and other STDs, but aren't getting tested. So how do we think about that? There's a lot of different ways to increase HIV testing. And so one of the things that we thought about was, how can we do more with the home test? So the OraQuick is a home test, self-test, that was approved a few years ago. However, it has limitations due to its high cost currently. It's access. You still gotta go into a pharmacy, Walgreens, go up to the counter and ask for it. It's behind the counter. So it's not like, you can't just grab a Snickers and grab your test and walk out like, in incognito. You still have to talk to somebody, which again, for a young person, a 16-year-old, a 17-year-old, can be quite intimidating. There's also age restrictions on the package. So even if you get it, you might look and say, uh-oh, I'm not supposed to do it. The age restrictions are really because it wasn't tested in this group, and there are concerns mainly around how youth will handle a positive result and if they will link to care. And so there's sort of this technology that's available, but it really isn't reaching the population that might actually like to use it the most because they're not accessing care. So we came up with an idea called test rehearsal, which is to use virtual reality to walk young people through all of the actions that would cause stress to get a test, to buy a test, to do the test, and to enter care. And so this is just a sort of one of our representations of a virtual, going behind, that's our pharmacist. She's got unusually large hands, but this is just a prototype. I'm not exactly sure what's happening there. But so the youth could be able to practice going up to the counter, asking for the test, maybe seeing somebody they know, walking by them at the same time, how to maneuver that. Conducting the test, so the ability to kind of, virtually open the box and see what's in there, to turn it over, to actually kind of almost, quote, feel what it feels like to have that technology in your hand. Then to practice doing it, and to, not just to sort of, all the tests come with videos where you watch a very attractive young man do the test. He's, very happy. He does it all. He's music in the background. He's waiting. While he's waiting, he's like reading all of the pamphlets. But what we know from studies is that this is not the scenario where this often happens, and people get freaked out. They don't know how to do the test. They don't, they're not exactly sure if they're doing it right. Swabbing the gums. Do I, what should I do? So this is sort of a way that, again, they would be able to practice, and the computer would be able to kind of assist and tell them if they're doing it right by sort of virtually practicing. Then waiting for the results. Again, it's supposed to take 20 minutes. So a lot of sort of ways for the youth to pass the time. So personalized sort of ability to choose YouTube videos that might be selected, that might be enjoyable, that would pass the time. Some simple relaxation exercises if that's your thing. Some people in my group, that's their thing. It's not my thing, but I would, I support it. So a lot of different options of ways to pass the time and to sort of feel like what it would feel like to wait, because that's obviously a big deal. Other things, interpreting the results. Again, from other studies that have shown that even though it seems easy, people aren't sure how to read the results. So a way to, again, sort of walk through in more of a hands-on way. And then the really important piece is what to do with the results. So this program is meant to be administered before they would ever take the test. So they can anticipate and feel like what the experience would be and walk through then what it would be like to either go with a virtual counselor to start PrEP or to start therapy. So really a way to then sort of have a full intervention that the youth could sort of decide if this is the right testing modality for them, and it may not be. The idea, this is a phase 1 small business grant, so it's meant to be about a year-long project, and the goal would be to turn it into a larger testing intervention where youth could have all different mechanisms of engaging with testing. Our next project goes down the cascade. So now, let's say you're positive and you're newly diagnosed. So a lot of newly diagnosed youth don't have a support system. They don't have anywhere to turn. They're scared. The information provided to them by the test, who gave them the result is, information overload. They may even come to one clinic visit and be overloaded and never come back. So the idea is to develop an online intervention where youth can get daily information and daily motivation and daily engagement with other like peers to address what it feels like to be newly diagnosed with HIV. This is an R21 that we're in the first year of to design AllyQuest. And for this, one of the things with technology is realizing that there's a lot of good work that's already being done by companies and by researchers that may not be exactly what you want to do, but it makes so much more sense to collaborate and adapt and enhance than to start from scratch. So that's what we did, and we found a partner called Ayogo, which is in Vancouver, which is a place I'd like to visit, so another reason to partner with them. But they have created a platform that basically does this, that sort of already is created to deliver information, to be engaging and motivating, and to have daily connections between peers. They developed it for 50s and above women who have diabetes. Not exactly the same target population, so we have to make some changes, but again, a lot of similarities in terms of what behaviors we're trying to change. We're trying to increase knowledge, we're trying to increase support, motivation, and skills to engage in care. So we're currently designing AllyQuest, and then in plans for developing a 1-month trial. We also partnered with our friends in Chicago at the Core Center there to have a little bit more diversity in our sample of youth. So this is, excuse me, this is our profile page. This is sort of the home page. This is one of my project coordinator's homepage. She likes otters, so because they're cute and silly, apparently. My picture is Dolly Parton, so I didn't want to show that. I thought that. I'm not sure why I'm telling you that, though. But she motivates me. So there's a lot of different features of this, and all of the features are sort of designed to kind of, again, move the youth towards engaging in care, getting on medicines, and taking their medicines. Again, moving everyone towards that end stage of the continuum of suppressing their virus. So some of the pieces of AllyQuest, and I should mention that all of this was developed with youth. So we have 2 youth advisory boards, one in North Carolina, one in Chicago, that have been instrumental. We've had monthly meetings with them, with email contact in between. We also have usability testing. So all of this has been developed with youth involved in the process. So the quests are sort of routine tasks that are meant to develop knowledge and skills. They're, again, a lot of them hinge on doing medical-related things, but some of them really hinge on other things that will build self-esteem and self-empowerment and the ability to, feel better about themselves moving forward. So again, if you do the quest, you can, check off that you've done it. Again, as in sort of any app that you do on your phone that sort of has a game feel, if you do something, you get points. Points can unlock things. You move up the levels. Things, make pretty little badges, and you feel good about yourself. Daily discussions, again, this is the social wall. This is the Facebook of AllyQuest, but it's focused, right? Facebook does not have a focus. At least none of the friends that I have on Facebook seem to. But this is sort of focused. So each day there's a new question or something that you have to sort of discuss on. You don't have to post, but you can. You can again, what have you gained from telling a friend your status? Again, this is us because we're still testing it out, kind of putting stuff in. But again, that's me, the Batman. Again, I texted my sister because I was scared to tell her, and then you can get comments, and you can go back, you can like statuses, you can go back to other and read and get tips. And the goal, we've created all of these discussions to, again, move people towards the end goal of adherence. Knowledge center. So again, what we know about interventions is that information is necessary, but not sufficient to change behavior. But we have the information in here. Again, the way we present it is in short snippets. A youth is not, especially on a phone, going to read, pages and pages of text. So we've divided them up into different ways of, again, looking at the information so it's digestible, and they think about the information they read to hopefully incorporate that into their lives. One of the things that unlock as you go forward and get points are these choose your own narratives. We have a group of recurring characters. We've elicited some young MSM to help us write these stories. We've also been doing them with our YAB. But the idea is that they, again, have a relatable story that you can choose different outcomes in a choose your own adventure kind of format and walk through it. And they deal with things like getting diagnosed with syphilis, or not getting to your appointment because you stayed up a little late at the club the night before, or getting to your first doctor's appointment. And again, each of them have a good ending, an okay ending, and a kind of not great ending. So you can try out different scenarios and see kind of what happens. And again, the goal is to hopefully the youth will incorporate what they're learning from the stories into their own lives. So for AllyQuest, again, we're sort of right now in the usability stage. We're still, there's also a medication tracker, which I didn't show because it hasn't been prototyped yet, but that will also, again, feed reminders for medication taking and develop strategies to help with daily adherence. So our next project, again, now we have people that are already in care, but what we've found, at least in the clinic where I work, so I'm a provider in a clinic also, seeing youth, what we found is that a lot of these youth are struggling for information when they enter care. They don't want to go to support groups because all the support group people are old. No offense, because they're like my age, but they're not young, they're not newly diagnosed, and they don't want to go to those, but they don't know where to get information. There are some websites that have great information, but again, they want something that they can go to that's sort of just their own. So we created Bijou, which means shine bright. And this is funded through our Ryan White grant. That's actually a collaboration with Duke. And so through that collaboration, we applied for a supplemental funding. So 1 year of funding, I think. Yeah, Julia is telling me, yep, you're almost done. But 1 year of funding to develop an intervention for newly diagnosed young MSM that could be delivered in the clinic or at home, but would be able to, again, walk them through sessions around self-management. And so there's been a lot of sort of interest in chronic disease management into helping patients learn how to manage it themselves. And so there's a group that has developed a lot of these modules, one for HIV patients, but really developed for older patients with HIV that are not sort of doesn't deal with some of the specifics that are relevant for our population. So we, meaning Helene, my project coordinator, and myself, have sort of created modules that are all delivered online and adapted for young MSM. So this is Bijou. All of the imagery, again, has been selected to represent the target population. As what we found in a lot of our formative work through technology is that people like to see progression through their intervention, to see progress, but don't necessarily want to show their faces on these interventions. Part of the beauty of online is anonymity. So Bijou, again, shine bright. This gem, a lot of our imagery on this site is really sort of progression of a gem, that as you get this information, as you interact with the program, you become more fulfilled, more sort of multifaceted, you're sort of able to shine bright. So these are our different sessions. Again, health literacy, managing HIV, personal growth, health and wellness, relationships, and problem solving and coping. Again, one of the things that you might sort of stand out is that there really is only one or two of the sessions that deal just with HIV. And those are the early sessions when people need information. Most of the sessions deal with things that probably are relevant to most young men that may not have sort of learned how to deal with finances or deal with stress relief or have great communication and stress management skills. So this intervention hopefully has more applicability to not only HIV patients, but to youth and adolescents in general. Again, this is, I think the light, it doesn't come through as well, but this is sort of one of our sessions. And again, what you can see is that everything is broken down into smaller, bite-sized chunks. Nobody wants to, get online and do, like one of those HIPAA compliance modules, right? That, those are the most awful things in the world. But, where you have to go through and you have to answer all the questions, you have to read all the slides, there's stuff about Medicare. Like, you want to you have it something interactive that's broken things up. So what we do is we have, again, there's text, there's interactive exercises, there's different ways of presenting the information, there's videos of myself. They're a little low budget, but they're filmed in my office where basically I'm sort of answering a mailbag question via email that would be sort of a typical question that a youth might ask around the topic. So a lot of ways to break things up, benefits and challenges. So again, pulling on things from theory that we know work, creating decisional balances around what's beneficial to go into clinic, what's not so beneficial, and weighing those things. And again, as they progress through, they can see their progress, and hopefully that will continue to motivate them. This is one of our other sessions, personal growth. Again, you can see each of the sessions has a different color to sort of, again, all kind of go with the theme of making your gem bright. Again, it's supported by a peer forum. It's supported by a peer forum where the youth, again, they're going to be enrolled in a cohort where they can, again, talk with other people that are enrolled at the same time. And again, it follows along the line of their sessions. And then it's supported by what we decided to do was a weekly check-in with our social worker. So again, what we asked our youth in our Part D program was about attending in-person support groups, and no one wanted to. But there was a lot of interest about doing it online. So each week, the session is supported by a weekly support group where the group will reflect on the themes of the session with our social worker. And so we're currently in the process of usability testing the platform, and we hope to start the kind of pilot trial in the next few months. All right, so we're moving along the continuum. So now you have people that are in care, right? They're diagnosed, they're in care, but they're just not on medicines or they're not taking their medicines. And what we know is that this is from, again, data that looked at a bunch of different trials with youth, and we know that youth particularly don't do well with taking their medicines. It's not surprising, right? The youth brain doesn't necessarily plan. It's not used to taking medicines or doing anything at the same time every day. We've come a long way by the fact that we do now have one pill once a day to treat HIV, but even that is challenging. So we have to think about new ways to engage youth to take their medicines. This is data that we published from the Adolescent Trials Network, which looked at behavioral and perinatal youth and rates of adherence. Again, were lower among the behavioral youth than the perinatal, but all along people were pretty poorly suppressed. So we created Epic Allies. Again, an idea of creating an intervention that was engaging for youth, that motivated them, but then also addressed the key issues with taking medicines. So Epic Allies is really kind of game-based. It's sort of something called gamification, where you sort of incorporate game-based elements into things that wouldn't normally be a game. So taking your medicine, not necessarily a game. But turning it in that way, again, becomes more engaging. However, I'm not like the creator of Angry Birds. So, we have to sort of also, remember that we're working on, public health monies, and, my background, while it is English, is not game design. And so, really thinking about how do we engage youth, but also still make it relevant to kind of what we're trying to do, which is change their behaviors. So the story is that you're in Medopolis, which is, has a toxic waste, and you have to work with other people in Medopolis, your Epic Allies, to address the toxic cloud, and you do that by taking your medicine and being part of the team. Again, avatars is sort of an area that, again, has shown that youth feel more engaged if they have some visual representation of themselves. Our intervention is for young monosexual men and transgender women. So, one of the things we wanted to make sure is that our representations of body shapes were both feminine and traditional feminine, traditional masculine, but it had a lot of different options for skin tone that was not just sort of along the typical lines of skin tone, but also included a lot of different ways that people could represent themselves so everyone would feel included. We have masks, we have symbols, and as you progress through, you can also earn new suit colors, new shapes, new masks, new symbols. Again, one of the important things that we've learned from adherence interventions is that weekly text messages does appear to improve adherence, at least in 2 trials that were done. So we wanted to make the opportunity for youth to get reminders through the app so they can set reminders, which again comes through. Again, here's sort of the interaction. So people get messages sent to them if they're doing well or not doing well. These messages in this sort of version of Epic Allies are already pre-written. One of the things that I think in a future iteration we wanted to do was allow more ability for youth to communicate directly and for providers to also engage. But in this sort of prototype, at least the youth get sort of messages from each other. And then daily, they are encouraged to fill out a survey. And again, this sort of can map different behaviors because what we know is that it's not just about HIV for youth, right? And that a lot of these other things, mental health issues, substance use issues, smoking, impact their ability to take their medicines. So this survey, again, all the data gets stored, and then based on how they've done over the week with taking their medicines and other behaviors like smoking or alcohol or drugs, they get tailored feedback. So again, this person, Walter, who's our sort of virtual coach, realizes that that's probably Sarah. Sarah didn't take a lot of her medicine and was doing a lot of smoking. To her credit, she didn't smoke a lot of weed that week, so it was pretty good. But basically, Walter told Sarah, you're not doing so great. But the motivation is there, right? So the journey to a week of adherence begins with taking your meds today. It's very zen. But they're all motivating. But they reflect on what the behavior, what they've done. So again, if they were drinking excessively and not taking their medicines, that tailored message will say, it seems like you might have been, drinking a little bit, maybe it was a week where you had a job talk and a grant reviewed and, one of those weeks. We get it. But maybe improve next week. So the tailored feedback, again, is hopefully kind of motivate them to feel that the app is actually relevant. Again, information we've talked about. So, how do you present information that's interesting? We have the daily dose, goes with the theme, has information daily. Not only do we have kind of it sort of in the form of just informational, but we have quizzes that they, short quizzes, again, that they can answer. We have Ask Dr. W. I'm free, so I serve as the doctor all the time. We also have 3 young guys who kind of tell their story in snippets, who are all different sort of dealing with HIV in different ways. And again, this is sort of the other pieces that they have is that, how do you reward people for doing the things that they want to do? And so we have mini games that they get tokens for that they can play. the game. Some of them are sort of like a target shooting. One is a running and jumping game. One is a bomb defusing game. So they're actually kind of fun. I can't do the running game, but my 5-year-old is, or my 9-year-old is excellent at it. But I splat myself against the wall constantly. But I can do the bullseye. But you get coins, and you can use those coins again to get more suits. There's kind of a Plinko machine. If you guys are, most of you, too young to watch The Price is Right. I'll look at the front row. No, just kidding. Just kidding. No. No. But you basically have a coin that goes down this slot, and you can win new dresses or avatars and things for your person. So we're currently in a randomized controlled trial of this study. We're at 4 adolescent trials network sites throughout the country. I think I put them in the right spot: Chicago, New York, Tampa, and New Orleans, and then some sites in North Carolina. So we're hoping to get to 200. Again, this is our primary outcome is viral load suppression. All right, we're almost there. This is exhausting, right? So our second to last, I think, intervention is called Tough Talks. Again, I talked a little bit earlier about virtual reality and how we can use virtual reality to simulate current, real things that are happening in folks' lives. Tough Talks is our virtual reality platform that is meant to stimulate interpersonal conversations between young MSM and their partners. The first sort of version of this is to work to develop a disclosure scenario. So having youth be able to practice disclosing their status to a sex partner, see what the response is, and then adapt how they might disclose in the future. Because what we know is that a lot of youth don't disclose their status. And what we know is that those that do engage in less condomless anal sex, which is the behavior that we know transmits HIV. We also know that having the disclosure conversation provides an opportunity for the negative partner to kind of know their risk and maybe get tested or get on PrEP as well. So a lot of sort of ways to sort of use this situation, this conversation, to move the field forward. So we've done, again, a lot of formative work. You can see from the kind of the theme of this is to develop these interventions, formative work has to kind of go into it. But again, we partnered with a company that knows what they're doing, so that have done and have developed virtual reality situations. In addition, we partnered with another company, so kind of a 3-way, that does natural language. So if anyone who uses Siri on their phone, again, my 5-year-old uses it quite a bit, but the Siri sort of interprets what you're saying and often gets it right and gives you information that's useful. So the idea for this is that the end result will be that the system understands what the person is saying, and the avatar that talks back to him says something that actually makes sense. So a lot of information going in that will hopefully create a realistic scenario to help youth practice. So these are our avatars. Again, we have 3 different avatars that look pretty realistic. Currently, the program is text-to-talk, so the user texts onto their iPad or their computer, and then the avatar provides an answer back. We call it the Wizard of Oz, because currently there's one of us, my folks behind the screen, that reviews what the machine says and says, yeah, that seems like a good response, and allows it to go through, or says, that doesn't make sense. You just disclosed your status, and he just said, yay, let's have pizza. So that doesn't seem quite right. So types an appropriate response. But the goal is that this will be fully animated, and we'll also be kind of, again, wrap around with a disclosure coach that will help guide the youth through the disclosure process, because not all scenarios are safe for disclosure. So if there are signs that it's not a good or safe situation, that coach would maybe direct them not to disclose. Again, we think this has a lot of implications for not just in the US, but globally. And again, not just with young MSM, but also with heterosexual youth, women, pregnant women, other sort of places where disclosure is really important. All right, so our final one is health empowerment. Health empowerment is sort of like my how many children do I have? 3? My 4th child. So it was my grant it was my first sort of large grant, and we're in year 5 of it. And so we've really worked health empowerment. I've learned kind of the most through developing health empowerment. When I started health empowerment, we weren't using mobile phones, or maybe like the cool people were, but not everyone. And so it was designed as a desktop intervention, really sort of you and the computer, point and click, and really sort of doing that. Then social networking happened. Facebook happened. Probably, I think MySpace happened before that. But the ability for youth to interact with each other rather than just the computer changed how we needed to design interventions, and mobile health happened. So throughout this whole process of the intervention, we've had to adjust and really kind of stay on top of what was happening with technology. But health empowerment was really designed to be a mobile phone optimized intervention for young black men who have sex with men 18 to 30. And the goals were really to address risk behavior, unprotected or condomless, we call it now. At the time, we still called it unprotected, anal sex, but also to promote overall health and wellness. Again, those of us who've been in North Carolina dealing with HIV for a while recognize that there's a lot of stigma around being positive, around being gay, and a lot of these dual stigmas impact self-esteem, impact social support, social isolation, and then obviously can impact risk. The intervention was designed for positive and negative youth. And again, this was kind of new at the time because people were sort of even our study sections that review grants were very strict. This is for negative prevention, this is for people that are positive. And so they didn't know really where to put this grant. But the idea was that you can't have conversations around these issues without bringing people that are positive and negative together in the same space. And in the real world, they're in the same space anyway. It's only in our intervention development where we make these sort of walls, these artificial sort of walls. Again, based on theory, and we had a lot of user input throughout, I think probably over hundreds of youth who helped us design this through all phases, even our Dead Christmas phase, which was when we had a backdrop that kind of had a grayish green and red that again, one of the users said reminded him of Dead Christmas. We changed that. We brightened it up. So again, this is what health empowerment looks like. Again, I said it addresses the entire continuum of care. So prevention, again, there's forums, there's videos, there's a question, there's, again, me, cheap. So videos of me answering questions around PrEP. So again, a lot of different ways to get information, but a lot of ways for the users to interact with each other as well as with the health empowerment crew. Testing, again, this is a forum sort of posting where somebody posted around couples testing and a lot of people talking about it. We also have testing locators on the site. Linkage and Engagement, we have a series called Voices of Empowerment, which was filmed by a young black MSM who interviewed young men all over the country to talk about what it was like to be either positive or in the field of prevention or what their experiences were. Again, we have ability to kind of rate and get information on different clinics, and then again, ways to set new goals around adherence. We have information, again, a whole section as another theme, a lot of information. Again, one of the favorite sections is a quiz section where people can move up different levels. And again, some of our quizzes are around adherence and taking medicines, and some of our quizzes are about Black history or social media or grab bag. So we really try and make the site engaging and useful. We have monthly contests on the site where they got swag from our site. So they, again, as with sort of the other interventions, as they move up, you can see the diamond over there. As you move up, your status increases on the site. You get points. You can buy things from the site like iPods or sweatshirts or cute underwear or water bottles or T-shirts. You really, the goal is sort of the more you interact with the site, the kind of more higher your reputation is, and that is reflected in your profile. We have preliminary results, literally like hot off the press, like 2 days ago, and performed by folks at Duke. So if there's errors, that's not my fault. my statistical consultants. But I think, we enrolled 474 young black men in North Carolina for this intervention. They used the site for 3 months, and then they're followed out to 12 months. Our retention at 3 months was 86%, right? 85? Yeah, 85, 86. Our retention at 6 months is 79%. So number one, we're just ecstatic that we have high levels of retention. That's really has nothing to do with me and everything to do with the folks that work with me. But I'll take credit because I'm up here. But we, this is one of probably, if not the largest sample of black MSM, certainly in the South, with a mixture of positive and negative. So we're really excited about the wealth of data that we have, even just in our baseline sample. Young, our mean age was 23. Again, levels of education. A lot are currently employed, although most of that is sort of part-time driven. If you look by their income, about half made less than $11,000 last year. So again, low levels, large sort of how do you describe yourself? Majority describe themselves as gay, but 18% bisexual, 2% identified as transgender. Although what we know is that some folks transition throughout the course of health empowerment, which I think is going to be sort of another just small numbers, but very interesting. High levels of testing for HIV. And again, 40% of our samples positive. So again, as I said before, we targeted kind of both in terms of our recruitment. And so a lot of interest. Our entry criteria was unprotected anal sex in the last 6 months, but 2/3 had it in the last 3 months. High levels, about 50% were had clinically significant depressive symptomatology. Did I say that right? Did I do that okay? Okay. And then about a quarter had moderate or severe anxiety. So again, I think a sample that is pretty representative of what we're seeing in terms of others at other larger sort of metropolitan areas. We looked at internet use. Again, 7.3 is the median mean internet use daily. Again, it's probably comparable to those in the room. And 96% had a smartphone. That wasn't an enrollment criteria, but most had it. Again, most are on social networking sites. Again, you can see 98% and use those sites pretty frequently. So kind of capturing a population that's online all the time, and trying to sort of see if what we can sort of design something for them to go onto as well and compete with all the other stuff that they're using. So this actually made me cry. This was the prettiest graph I've ever seen. Sarah sent it to me. I literally teared up. I made her run it 4 or 5 or 6 times. But this is our preliminary results, which seems to show there was an effect. If anybody has wood around them, knock. But it did show that, at least in our primary outcome of unprotected anal and vaginal sex, that there was a decrease over the 3 months in the treatment group, while an increase in the control group. I should say the control group got sort of a list of, or got a website that just had informational articles only on safe sex and HIV and STDs. So obviously this is preliminary data, but the fact that the red curve is going down and the blue curve is going up is better than had it been the opposite way. We also, again, when I started doing this work, I thought, the be-all, end-all was risk reduction in terms of sex. And I think as I've done this for, many years, I've started to become, maybe I'm more touchy-feely, or maybe that has nothing to do with this, but there are other pieces that are so critical to this in terms of social support and social isolation and mental health that are really so important, particularly for this population. So one of the things that we looked at, this is an abstract that we submitted to the international meeting that we'll, I guess, hear about soon, is, not just around kind of the risk, but what are some of the other effects that health empowerment could have in this population, and will those effects persist over time? 1/3 of our sample was socially isolated, and what we found was that, again, and not surprising, this is just baseline data, but that social isolation was associated with sort of different usage of different websites, as well as less usage. So, again, as we think about kind of technology interventions, understanding kind of who's on what sites, what they're using them, why they're using them, and how we can incorporate our interventions and our messages in what they're doing to help decrease their risk. So my final thoughts, again, I think for us, we're very sort of firm believers that technology has a role in facilitating recruitment. I think if you're going to do a study with youth and you don't look online, you're not going to get the sample you need. So it certainly helps with recruitment. It helps with retention. A lot of our efforts for health empowerment were text messaging or Facebook's. I almost call it Facebook stalking because that might have an IRB implication. But contact on Facebook and really engagement. Technology cannot take the place of being one-on-one in a provider room with a patient, right? I have really, I try to have very good relationships with my patients, but I'm with them for 20 minutes, once every 3 to 4 months if they show up that month. And so what happens every other time when they're outside of there? How can I extend my reach? How can we extend our reach? And how can technology, work to our benefit to provide those messages when they're not sitting right in front of us? It's, again, once you develop them, they're very easy to disseminate and kind of, again, if you're lucky, they'll have sort of a wider impact into these established networks. One of the ways that we started to get people to come into our study was sort of by telling them to, tell their friends. And one of the things that we saw on health empowerment specifically was that the more people talked, the more people talked. And that, initially we were having to post pretty frequently, and then all of a sudden we didn't. And they were having conversations that were really, some of them very intense. Right now there's one, not surprisingly, about some of the laws happening in North Carolina and Mississippi. But there's been conversations around a lot of stigmatizing topics of being a top or being a bottom. There's been really fascinating things on manscaping. Again, feel free to ask me about that later. But a lot of very interesting sexual health-related topics that never sort of went into a realm that was inappropriate or sort of sexually charged. And so I think a lot of great information, a lot of great conversations have come out of this. Again, I think youth particularly, not just those that are HIV positive, but really all youth, either sort of dealing with prevention issues or chronic diseases, could benefit from some of the work that we've been doing and sort of translating a lot of what we've done in terms of establishing social support, social networks, providing real-time assessments. Again, you can see how some of this would be relevant for a young person to help them quit smoking or to decrease their drinking, or with diabetes to check their insulin, or with CF to do their thingy vest. I was just on service. It's like I don't know what it's called. It's a vest. But again, a lot of the different things that you could see could be helpful, not just around HIV. I think that one of the things that we've learned in this is that you have to be agile in not only kind of how you think about what you're designing, but what's going to be relevant 2 or 3 years or 4 years when your funding might come through, as well as, innovation is not necessarily creating the newest app. It seems like it should be, but I think actually that is probably not the right way to go now. The innovation is finding an app that's already been created and adapting it to sort of what you need it to be, or building off of some successful pieces of an intervention that have worked. So it comes from not only kind of understanding the field, but also understanding how to analyze these interventions, because it's not necessarily the whole of it. It may be that health empowerment, most of it didn't matter. All this stuff we did, but maybe the one thing that mattered was X. And if we just do X, it would have worked just as well. And so as we move forward, we have to think about how we analyze our interventions and then kind of what are the next steps, because particularly as funding dollars shrink, but also really I think that's sort of the good science, and that's where I think the fun of it is because a lot of people are really invested in doing this work really well and much better than me for sure. But so how do we sort of create these partnerships and work together to move the field forward in a way that, again, facilitates the highest level and the most cost-effective dissemination to make the best outcomes. A lot of thanks, a lot of partnerships. Again, Duke, I made you guys the biggest. Did you see that? You're like almost, you're pretty big. So all of my folks at DGHI, as well as others, particularly Sarah, Colleen, and my Part D folks for working with me there, and then our partners, and particularly my BATLab folks, so Kate and Karina, Helene, Kelly, Joaquin, who really, and Sulki, who really kind of do all the work and then let me stand up here and take credit. So thank you.